Well, we're going to move on. We've asked our speakers if they speak less than 25 minutes, then we can have time for a Q&A. And if they speak for the whole time, we should bring our questions to them offline. You can email us. We'll put you in touch. Our next speaker today is Dr. Jennifer Stevens-Lapsley. Dr. Stevens-Lapsley has been speaking for PALTmed for many years, and I will admit that every time after I hear her speak, I try to walk a little faster and take better care of myself. So, please welcome Dr. Jennifer Stevens-Lapsley.
Hello, and thank you for the opportunity to speak with you today. I really love this conference for a lot of different reasons. I'm going to start out, I don't have any disclosures, but I want to start today with a patient that you already know. You may not know his name, but you know his story. He's 88 years old, living at home independently with his wife, cognitively intact, married 50 years, 2 kids, but then he fell. He fractured his femur, his pelvis, and his humerus. So he was hospitalized. He caught COVID in the hospital. And like many older adults, he was eventually transferred to a skilled nursing facility. He had one simple goal. He wanted to go home. Now I want you to watch, before I tell you anything else, I want you to watch how he stands up and sits down. What do you notice? What does this tell you about his strength, his balance, his potential? Now let me tell you a bit more. He's been in the nursing home for almost 2 months, and his progress has plateaued, and he's receiving fairly minimal rehab. He was given some seated exercises, a seated knee extension exercise, and essentially ankle pumps. And he was told he could not practice getting up and out of his chair unless someone from the facility was with him. And of course, the facility was short-staffed. So he could not practice the very exercise that he needed to go home. Watching him sit in that chair was very uncomfortable, because I should tell you that this individual is my uncle. His name is Dave. And as a clinician, as a researcher, and as a family member, what do? I stepped in. I told him, you better park that chair against that wall with the brakes on. Remember, he's cognitively intact. And you better practice that exercise, that sit-to-stand exercise. And he did. And his trajectory changed, and he went home. But I should not have had to step in. A family member should not have to step in order to get evidence-aligned care. Uncle Dave didn't go home because of what I said. He went home because the practice, the intensity, and the activity finally matched his potential. And the uncomfortable truth is that too often, this doesn't happen in our clinical environments for fear of injury. As a rehab profession, I can tell you, as a physical therapist, we've already said this kind of care should not be happening, and yet, you'll see shortly, it's pervasive. Raise your hand if you've heard of choosing wisely. Good. So, choosing wisely represents moments where professions came together and said, we know better than this. So with nursing, it's don't let older adults lay in bed or get out of a chair, or only get out to a chair during their hospital stay. And for rehab, it's don't prescribe underdose training programs. And yet, if you think back to my Uncle Dave, he was sitting in a chair doing low-dose exercises with intact cognition and a clear goal of going home. So the problem wasn't a lack of guidance. The problem wasn't a lack of evidence. The problem is that what we say we value and what our systems actually support are often not the same thing. So let's zoom out a bit. Imagine 100 evidence-based practices were developed today. How many do you think would make it into our clinical environments? Only 14%. And how long do you think it takes for those evidence-based practices to make it into clinical care? 17 years. Show of hands, how many people think that's a reasonable amount of time to translate evidence that we know works into clinical care? Think of all the families, the patients that are impacted that missed out and could have benefited. Then even when the evidence is implemented, adherence drops by half a year later. So what if I told you we could decrease the time, the lag to get high-quality evidence-based practice into clinical care from 17 years to as little as 5 years? And that we could change the chance that Uncle Dave would receive treatment aligned with evidence-based practice to 80% rather than 14%. The good news is, more recent evidence suggests we can do this. We can take care and change and translate evidence into practice in less than 17 years. And how this can happen will be the focus of what's to follow. Think of a time when you tried to implement something in your facility. Did everything go perfectly? Was it smooth sailing? No bumps in the road? Or did you feel like you were trying to forge this river on your own? It turns out there's so many factors that impact our ability to get evidence across the bridge and into practice. Raise your hand if you've heard of implementation science. Okay, we got a good number of hands. So even though we have the best evidence, in this case, we need to increase mobility and increase the intensity in our post-acute care settings, without the right implementation environment, it just won't succeed. And so implementation science is a science that helps us translate things into clinical practice, evidence-based practices that we know work. So taking evidence to practice, crossing that raging river, and implementing using this particular methodology. So our patients and their families often choose facilities and clinics based on what they can see from the outside. And it's usually at first glance. Certainly other factors that go in, but facilities can look very similar on the outside. But the internal differences are what drives the actual care that patients receive. So consider two facilities that look nearly identical. We're going to call them Mediocre Meadows and Get Up and Go Gardens. I hope you're already thinking about what distinguishes these two facilities, because the rest of the presentation I'm going to contrast these two. So over the past 5 years, I have spent a lot of time in facilities across the country observing clinical practice. And I spent a lot of time in the rehab gyms. And what I typically see is a 6 foot, 300-pound male with a 2-pound ankle weight strapped around his ankle doing a knee extension exercise that's intended to strengthen the quadriceps muscle to help an individual get up and out of a chair. But the math doesn't add up. The physics just don't, it's not the right dose for that individual. And so it's very much like prescribing medication without having the right dosage based on physiologic parameters. And this disconnect rarely results from a clinician's negligence or lack of caring, even in the case of my Uncle Dave. Instead, it reflects the cultural norms and the leadership signals within, in this case, clinical environments or rehab environments. So in settings where productivity pressures dominate, where clinicians receive limited guidance on dosing and progression, and where risk aversion outweighs functional goals, these low-intensity practices become normalized. So let me tell you a story about Elaine. I walked into a facility and I was watching a therapist working with Elaine doing a sit-to-stand activity. And Elaine was using the arms of the chair to stand up and sit down. And I asked the therapist, can we try that without arms? And the therapist whispers to me, she's 95 years old. I said, I know, let's give it a shot. And sure enough, she was able to do it without arms. So I said, let's put a weight vest on her, at which point the therapist really thought I'd lost it. But acquiesced, and by the time we finished, Elaine had 30 pounds of weight on that weight vest doing a sit-to-stand activity without the use of her arms. And she started with that exercise with her arms, right? The therapist made an assumption. She's frail. She probably can't do this. And yet she was capable of more. So we were able to turn her facility into a Get Up and Go Gardens. In contrast, as I've been traveling around the country, this patient, if you can see, is pedaling on the exercise bike. What may not be immediately apparent is she has fallen asleep. In fact, I'm not sure she was pedaling at all ever. She's passively moving her legs because the machine is set on a passive mode. And if you look at this screen here, she's been doing this for 13 minutes with no resistance, no force registered. Mediocre Meadows. Sadly, she was not a one-off. I can tell you that there's a large number of facilities where I walk in and someone is asleep on the exercise bike. So we're going to use implementation science to examine how to address a pervasive problem that we saw with my uncle by trying to implement evidence with high intensity. And so I'm going to share with you a program that we've developed. And some of you, if you've been here before, have seen elements of this, but I'm going to share with you the results of our clinical trial in thousands of patients. And the basic premise behind what we're doing is we're taking current rehabilitation, which tends to have very little emphasis on this high-intensity resistance training, and we're taking that and making that the foundational pillar of what we're doing. So we're flipping this pyramid essentially upside down. And so it's called I Stronger. It's a practical approach for increasing the intensity of every activity someone's doing. It's not just weights or machines, it's functionally based. And it allows for more patient engagement. It allows for more patient function, improvements in patient function, clinical engagement, and we really hear good things from our therapists as well as the patients. And you can do this with any patient at any level. Someone could be bedbound, and you can still increase the intensity of activities and dose appropriately by having them roll or do different types of things in bed. So it's not just doing a sit to stand per se. And we can do it with toileting. We can have any discipline doing this. We can have nursing be actively engaged in doing sit to stands while they're doing toileting or while they're getting someone ready in the morning or walking to dine. You can have intensity of speed of walking, as many have alluded to, be part of how you're dosing and how you're progressing individuals. And the intervention ultimately doesn't take more time. But what we teach people to do is if you can do more than 8 repetitions of any activity, you need to up the weight or change the level of difficulty with something that you're doing. And this is true for all of us. And in a study that we did in our state vet's home on campus, over 100 veterans, we demonstrated that this works. This group had an incredibly cohesive culture, leadership, really all the things you need in order to drop something like this in and make it work. And they demonstrated that not only was it safe, but we were able to discharge 20% more people home rather than convert to long-term care. We were able to decrease the length of stay by 3.5 days. And we were able to increase walking speed, which you have heard alluded to, by a clinically meaningful and clinically significant amount. And so that was the foundation for a larger trial. And what we saw and heard from the therapists were that they really had no idea how much they were underdosing their patients. In many cases, they just assumed that someone wasn't capable of something because they looked frail. And when they started increasing the intensity, they got a very different result. And at the same time, they found that the patients were more engaged. A lot of patients really felt like when they came in and did this high intensity approach, they felt more challenged and they felt like they saw the results, they saw the benefits, and they were eager to come for therapy versus getting more refusals. I don't know if this video will play. I should have tested it earlier, but let's see. Well, we may not get the audio on that. That's okay. He's telling us about his experience with high-intensity rehab and how motivated it made him to keep trying to do more. Patients see people wearing the weight vest, and they want to be trying the weight vest, and they want to kind of follow in other people's footsteps. So it kind of creates this kind of fun competition and stimulus in many cases. So the randomized control trial was done with sites across the country, 30 sites. We randomized at the site level. So we took clinics that they were either usual care clinics where they continued to do whatever their normal practice was, or they were randomized to this high intensity group. And we followed the intervention phase was 15 months long. And we trained 140 clinicians. We did 170 focus groups and interviews and compiled all that information on almost 4,500 patients. And it has been such a pleasure and a joy to work with these therapists at facilities all around the country. And the results of the trial, just to give you a sense of the participants, that's usually the best starting point. You'll see that, on average, they're around 79 years old, more women than men. Length of stay was about 17 to 18 days, and the rehab kind of period of time was a little shorter than that. And OT and PT minutes were about 11 hours during that length of stay, 11 hours each. All the models and all the analysis that I'll share with you are controlling for age, sex, and baseline value of the outcome, in this case, gait speed. So, our results. When we look across the entire trial, in our primary outcome, which is change in gait speed from admission to discharge, both usual care and iStronger groups improved a clinically meaningful amount. But we didn't see superior improvements in the iStronger group. Of course, that led us to pause and go, wait, what? And I will tell you that this was an intent to treat analysis, so all eligible patients were included, whether or not they actually received iStronger. And so we took a little bit of a deeper dive to look at the dose that patients received. And what we saw was, I should really highlight that we did not see any adverse events that were directly attributable to any of our high-intensity activities. We had 23 adverse events in the control group and 23 in the intervention group. So I think that's a really important finding. At the very least, this approach and this methodology does not cause harm, and that was really important, I think, for the clinical community to see in order to feel comfortable pushing the envelope. Our results, when we look at the dosing, so the dose of iStronger that patients received was a really important part of this. We started this trial in 2021, and you can imagine that was still post-COVID, where facilities were still having outbreaks and shutting down wings and all the things that made it difficult to implement rehabilitation as intended. And so what we see here is there's a group, roughly 11%, who received no iStronger sessions, and a group where all their rehab sessions were iStronger and everything in between. But a large percentage of people that didn't actually get the intended intervention in the dose, even at the iStronger sites. So seeing this distribution, we wanted to understand the relationship between dose and outcome and understand how much dose was needed to see a clinically important difference beyond what we saw in usual care. And what you see here is that relationship. So the x-axis is the dosage of iStronger as a proportion of their total sessions, and the y-axis is the predicted change in gait speed from baseline to discharge. And this regression line represents that for every 10% increase in the iStronger session, there was an improvement in gait speed. And we know that everyone on average, there was an improvement across the board. But how much was this? What was the amount that was above the clinically meaningful improvement? And what you see here is that a line is drawn to show you the MCID, and you had to receive 70% or more of your sessions as iStronger in order to exceed the minimally clinically important difference. And so that means that if you got 10 sessions, you had to have 7 of those sessions be iStronger sessions in order for patients for us to see a meaningful improvement in outcomes. And so when we go back now and look at how many patients got 70% or more of their sessions as iStronger, that was not, you can see here, there were not a lot of people that got greater than 70% of their sessions as iStronger. And so so speaking to kind of the challenges with actually implementing this, especially in a post-COVID era. But dose, so ultimately you have to have the dose of the intervention in order for it to fully evaluate whether or not it works. And so dose is directly related to effectiveness, but our prior dose analysis really just looked at the rate at which we implemented iStronger, and it didn't necessarily look at the fidelity or the quality of implementing iStronger. And so when we looked at the quality piece and we factored that into what we were doing or analyzing, it's important to consider and to emphasize that because there's so many things that are factoring into a multimodal intervention, that the implementation success really depends on this critical combination. And what we saw was when we took the data, the ethnographic data that we had from going into facilities, being present in person, watching what was happening, we combined that with the interview and the focus group data, along with the fidelity data. We did a lot of checks both in person and from a distance. What we saw was a distribution of facilities from high, moderate to low in terms of their implementation success. And that was really important because basically we found that some facilities did a really good job of implementing iStronger and others did not. And when you look at this graph, which is effectiveness by implementation success, the black represents the usual care group and the change in gait speed. And the gray, the first gray piece there represents the facilities that were low quality implementers. And you can see that they are significantly less in terms of their effectiveness than the usual care. So if you were a low implementer, you were worse than usual care. If you were a high implementer, which is on the far right represented by that teal bar, you were significantly better than the usual care arm. And so ultimately, patients at high implementation success sites improved more than patients at usual care sites. So contrasting again this concept of our mediocre meadows with our get up and go gardens. So there were lots of factors that explain the dosage and the implementation. I want you to take a look at these. I'm not going to read all of them, but we had clinician-identified factors. They thought certain patients were maybe less likely to benefit, and we're still working on analyzing some of that data for whom and which subgroups of patients does this work best. But these were the clinician impressions. There were also many clinician factors that contributed to success. And training was challenging. Not all, turns out only 1/4 of all clinicians on the roster for the therapy group that we were working with ultimately got the training. So lots of challenges with getting the right training to the people that that were providing the intervention. And then when you look at organizational capacity, this is probably the biggest one. I really want to highlight that there's lots of issues with staffing and productivity and space and equipment issues, but leadership and culture, that was one of the big things that I saw when I went into these facilities time and time again. And so I want to kind of emphasize that piece, because when we think about this bridge where we're trying to connect evidence, this is the same bridge we saw, crossing the river, but it looks really straightforward to implement something like iStronger, but the reality is it takes 17 years to cross this bridge, right? And what's missing in many, many cases is leadership and culture. And it's not surprising entirely, because we aren't always trained in this way. So many of us have taken clinical education courses, but we haven't necessarily been taught formally, been given leadership training. And so addressing conflicts with an employee or giving feedback to a poor performer. And so if we want Uncle Dave ultimately to be able to go home, maybe we need to be thinking about not only the clinical skills that it takes to implement best practice, but the environment and the culture and the leadership in order to really translate some of our practices into reality. And so ultimately, it's this trying to take 17 years and bring it down to 5 years. And so when I think about iStronger, and if you want more information on the program itself and how to implement it, there are some resources using this QR code. But when we think about the lessons we've learned through the work that we've done, one of the take-homes is that high intensity is safe, especially when you're monitoring vitals, and we teach our therapists to do that. And patients really they really engaged with iStronger. We all know there are some patients who are not motivated, and it's really hard to get them to do anything. But the large majority of patients were really excited and engaged. And many patients who had been at previous facilities and knew I was kind of watching what was happening would come up to me and say, the therapy here is completely different. I feel like I'm really getting something out of what I'm doing. Key element that I always get asked is productivity. We didn't see any decrease in productivity once therapists learned how to implement this program. And we are still trying to figure out for whom does this work best. So we're still figuring out do patients with dementia or patients with high levels of pain in our large scale analysis of thousands of patients. as well as, because there was an implementation challenge, how do we optimize training? How do we make this effective on a large scale for individuals so that the implementation isn't so challenging? We also have published something showing that if you add a mobility program in addition to the high-intensity strength training, you get an even better result. And so we're in the process of setting up a study that's going to evaluate just mobility by itself versus mobility plus iStronger. Maybe just walking patients more in the facility gets them to their goals in terms of function and improves outcomes. So we need to continue to think about that. And in fact, with that in mind, we are hosting a conference called Mobility Matters that is intended to be a work group to figure out how can we get individuals more mobile in our skilled nursing facility settings, and how can we work together. And so we're bringing together leaders in policy and clinical care and research and innovation to really create a think tank for how we could really address this culture of immobility. I have more information if you are interested in joining us for that conference. So I want to close by bringing us back to where we started, to Uncle Dave, sitting in that chair, capable of more, but not being asked to do it. What we saw today is not necessarily a lack of evidence, because we've known that exercise intensity matters. I've shown that it matters in skilled nursing facilities specifically, and that it's safe. But we know that low-dose care leads to low-dose outcomes. And if we want evidence-based rehabilitation to succeed, maybe it's not just about the intervention and the evidence that we're looking for. Maybe we need to start treating leadership and culture not as background conditions, but start treating them as clinical infrastructure. And ultimately, that's how we can go from mediocre meadows to get up and go gardens in less than 17 years. And when we get this right, the impact is real. It shows up in real lives, and it's deeply personal. It looks like Uncle Dave going home, and my hope is that we can make that the standard and not the exception.
Thank you so much for the evidence and the inspiration.